Thank you for the invitation to speak with you today. My name is Dr. Stefanie Green, and I will be sharing with you today my experience with assisted dying in Canada over the past 4.5 years. I am planning to not do so much of a technical review of our law or how we came to this place so much as to dig down into the detail of how assisted dying works. I think that's probably more helpful to most audiences, so I'm going to try to focus in that way. Usually when I speak, I quickly gloss over my own journey to the work. But in reading a bit of background for today's talk, I expected it might be a little bit helpful to spend an extra few minutes just on my own path to this care and why I chose to participate in assisted dying, how I learned about it, maybe even some of the things I've learned. And I do this for a different perspective on the larger topic. So I would ask you to indulge me as I tell just a little bit of that story. And I'm willing to discuss it in more detail later if it's helpful in any way, but I won't spend too long on it. As the slide suggests, I am trained as a family practitioner. I spent 10 years in general practice, everything from newborn right till end of life. I then spent the next 10 years exclusively focused on maternity and newborn care, which was a particular passion of mine. I've always been attracted to the intersection between medicine, ethics, and law. And so for most of my career, that was in relation to women's health and reproductive rights. But I've also had a very strong belief in patient autonomy and the importance of autonomous decision-making in my career. In fact, when I was in medical school, I carefully followed not just my classes, but the national headlines in Canada. At the time, there was a woman named Sue Rodriguez who was challenging Canada's law, Canada's ban on assisted dying. So it was, by coincidence, I was doing a bioethics course at the time, and we talked about her and her case in our courses. She eventually lost that challenge, but I have little doubt that that experience helped form my early thoughts about this field of care. And like many Canadians, I followed that saga for many years and the ensuing politics around it. In 2015 or so, I was watching as this new law in Canada was coming to fruition, and I was considering, by coincidence, a shift in my focus of my work. It was physically becoming difficult to regularly do 24-hour maternity call shifts, and my husband kept reminding me that it was taking longer and longer to recover from that. And I wanted to be home for some family responsibilities before my children left for more schooling. So on a personal level at that time, I felt assisted dying was a just cause, and it was right. I felt that our newly changed law was a very humane one, whose time had really come in Canada. And professionally speaking, I was at a place where I saw assisted dying as falling along the spectrum of what clinicians do. Because despite what we say or what we wish we might be doing for everyone, after 20 years of clinical experience, I think I was wise enough to understand the true essence of what a good clinician does is to help people in whatever form that might take. And there's an expression, I think it says to cure sometimes, to care often, and to comfort always. And I really believe that about my work in family medicine and as a clinician. And I felt that assisted dying was a form of help. So I wondered who would be doing this new work in Canada. I felt that I could be doing that work, and I thought that I might want to do that work. So I educated myself initially. I did a lot of reading, a lot of speaking to people, and I went to Amsterdam for a conference where I met colleagues from other jurisdictions who had experience in this field. And I returned from that trip quite committed to doing this work, and specifically doing it in what I considered a very transparent way. I didn't want it to happen behind closed doors. I came back and I started a website called Solace BC, which was for basic information for patients, for families, and for healthcare providers to understand how assisted dying in Canada would work, and how they could find me if they needed my help. And I co-founded the organization I mentioned, CAMAP. I found, interestingly, as I started doing the work, that I was using a very similar skill set. This is perhaps a tangent, but in maternity care, when I'm helping a woman prepare for and then eventually labor and deliver a baby, I know that there's a lot of preparation involved. There's a certain respect for understanding her own wishes. There's a significant transitions happening in various people's roles. There's a lot of family dynamics, a lot of emotion. And what I found was I could say the exact same things about an assisted death in that event. And so I found my skills transferable from one to the other. So it's a little bit about me. Next slide, please. So I'm a little bit unique. Next slide, please. In that 90% of my clinical work today is actually spent in assisted dying. It's very unusual. And in that regard, I've had the privilege of speaking to well over 350 people about their end-of-life goals. I've had the great honor of assisting over 200 people to fulfill their deeply felt wishes and to end their life. And I found the work very rewarding. And again, I'm happy to speak about that more later if there's interest in that. Next slide, please. People often ask me, who does this work? Who are my colleagues? Well, in my organization, we're about 350 people from across the country, and 60% of us are clinicians, in fact. But 40%, as I mentioned, are from allied health allies. So everything from pharmacists and lawyers and social workers. So we're a great variety of people that come together to do this very multidisciplined work. Of the clinicians in our group, 80% of us are primary care physicians or family physicians, not surprisingly. But the other 20% are nurse practitioners, because in Canada, both nurse practitioners and medical physicians are allowed to do this work. And of the physicians, 80% of us are family practitioners, and the other 20% come from a variety of backgrounds. And primarily we see anesthesiologists, palliative care doctors, internal medicine doctors, a few psychiatrists, we have some OB-GYNs. So quite a mixture making up the number of people and the types of clinicians that do this work. Next slide, please. I'm told that every international talk needs to have a map, but I'd like to think that this group knows how to find Canada on a world map. We are, of course, the northern of our southern cousins who are taking up the headlines these days. I'm sure you can find us. Next slide, please. What I really want to say, just in 2 sentences about the Canadian context, it's probably important to understand that our law is federal, and we have assisted dying legalized in every province and territory of our country. So it's a federal law. However, next slide, please. In Canada, healthcare is actually administered provincially. So we do actually see some differences in the minutiae of how things are done across our country, despite our law being national. So for example, what I write on a medical certificate of death in British Columbia might say that the patient had an assisted death, and then the secondary cause of death would be their underlying illness. Whereas in another province, they may have regional rules where they're not allowed to say that the patient died by an assisted death and only talk about the underlying illness. So there are details of how it's operationalized across the country, but the legalization is national. Next slide, please. I do want to just start off so we're all on the same table in terms of terminology. There's a lot of different terminology out there. So just to be clear, you'll often hear people talk about assisted suicide. We don't use that term in Canada. We talk about self-administered death. But I know in Europe and in the UK, this is probably a more common term. So an assisted suicide, to be clear, or self-administered death is when the clinician actually prescribes a medication that then delivers to the patient, who self-administers, it's usually a drink, an oral drink. So the patient will self-administer that drink and cause their death. The term voluntary euthanasia, or what I might call a clinician-administered death, is when the physician writes the prescription, gets the medication to the patient, but then it's the physician or nurse practitioner who administers the medication by intravenous route that causes the death. So really the only difference is who administers the medication. Of course, I'm always talking about a competent, capable adult who's made this explicit request under the law. Next slide, please. What's interesting in Canada is that we have both of these options available. So it could be either self-administered or clinician administered, and we have either a doctor or a nurse practitioner. Next slide, please. This puts us in a very exclusive club globally because it's only the Benelux countries and ourselves that have these options. Every other jurisdiction you hear about or read about in Switzerland, United States, and Australia, and now New Zealand, they have only self-administered or assisted suicide. Next slide, please. So I'm not going to spend too much time on the history of how we got to our law, because I don't think that's the bulk of interest today, but I do think the story is important so you understand how we came to it. So I would just say that this is really a credit to some courageous women, in particular, Kate Carter and her family, and Gloria Taylor. Kate Carter had a non-terminal illness. She had spinal stenosis that was causing intolerable suffering. And Gloria Taylor had ALS, amyotrophic lateral sclerosis, otherwise and commonly known as Lou Gehrig's disease. And these women felt that the Canada had a blanket prohibition for assisted dying, and they felt that they were being discriminated against in their particular situations, that they felt they should have the right to ask a physician to ask them to assist them to die. And I should make clear that this challenge to the Canadian law is what we call a charter challenge. This is a constitutional challenge. In Canada, we have the Charter of Rights and Freedoms, and these women felt that their personal human rights were being infringed upon by this blanket prohibition. And they went through the entire court system right up to the highest court of the land, to the Supreme Court of Canada. Next slide, please. And of course, in 2015, our High Court unanimously decided, 9 judges decided that in fact, the plaintiffs were correct and they were being discriminated against under our Charter of Rights and Freedoms. And they carved out situation where they felt if these things were true, the rights would have been infringed upon. And that was simply that that they were competent adults who had what was then called a grievous and irremediable condition that was causing intolerable suffering. And in that situation, their rights were being infringed upon if they didn't have the opportunity to ask for an assisted death. I'll just point out here that there is nothing in this decision about terminal illness or prognosis or end of life. It was a very more generic decision. Next slide, please. The High Court in Canada does not have the ability to mandate law, but they strongly suggested that our government regulate the practice of assisted dying, of course, and our government did that. And on June 17th of 2016, we took what is commonly referred to as Bill C-14, and it became law in our country. Now, the little green pentagon on the slide here is specifically smaller than the blue square because Bill C-14 is more restrictive than the High Court decision. So just to visually emphasize that point. Next slide, please. I'm just going to show you that trends-wise in Canada since 2016, every year we have seen an increase in both requests and provision of assisted dying, pretty steadily increasing. From at the end of 2019, we know there were just under a total of just under 14,000 reported assisted deaths in the 4 years of assisted dying. And that was an increase of 26% from the year before, from 2018 to 2019. So a steady rise. Not surprising that it's going up as it is still fairly new in our country, but we haven't yet seen the plateau, which we're expecting fairly soon. Next slide, please. I think it's easier to compare jurisdictions in a bar graph. So the first half of the slide breaks down the activity that's happening across our country in various provinces. You can see there's a slight variety in different regions, with the 2 provinces, QC is Quebec and BC is British Columbia, who are clearly more active in assisted dying than the rest of the country. That's probably because our assisted dying laws and court challenges originated in those 2 provinces, so a population that's a little bit more aware of the issue. You can see the bar that says CAN at the bottom. That's Canada's average. At the end of 2019, fully 2% of all annual deaths are attributed to an assisted death in Canada. You can see that we compare that to Oregon, which is next to it. Oregon, of course, the United States that has had some form of legalized assisted suicide since the late 1990s. They only have self-administration, which I think accounts for the difference in our activity. Compared to the Netherlands, which is next to it, again, about almost 20 years of experience with both clinician-administered and self-administered assisted dying. So they're doing about twice as much as we are, which is kind of what we expected. We're still quite new at this. The final bar on the end, I just put in as an interesting side note. I live on an island in Canada off the west coast of British Columbia. Our island is about 2/3 the size of Ireland with a population of about 800,000 people. So it's a very closed system. We are one health authority that administers health in that whole region. And for whatever reason, we have the most amount of assisted dying in our province, in our country, and as it turns out, in the world. So a unique place that I happen to live. Next slide, please. Very basically, the most common diagnosis underlying people accessing this care is cancer, which is consistent across all jurisdictions. The average age of the person accessing assisted dying in Canada is 75 years of age. Male-female ratios are almost equivalent every time we look at them at various time periods. And this is happening anywhere, I like to say, that's safe and legal. Primarily, this is happening in people's homes, also happening quite a bit in hospital settings. We see this happening in palliative care wards, seniors residence, assisted living, in all kinds of various residences. Next slide, please. So here's really where I want to focus my talk, which is on process. What does this really look like? How does this actually work? I'm going to be just a tiny bit theoretical at first, and then I really want to get into some examples because I want you to understand how this works. Again, in Canada, to stress, assisted dying is a patient-centered, patient-driven care. This comes from a charter challenge. This is based on human rights. It's patient-centered, okay? So if a person wishes to have an assisted death, they first have to ask for it. And the patient themselves must ask for it, and it must be in a written format. Next slide, please. So how is this done? How does a person make a request? How is this brought up? Who can bring it up? Who should bring up this topic? So, for example, this happens commonly in the primary care physician's office. A patient might be there speaking to their family physician, someone they've known for a long time who has followed them through various life events, including their illness, which they currently have. They may be at a stage in their care where they are declining, and they may bring it up themselves. Doc, you know me well, you know my thoughts, can you tell me about this thing I've heard about assisted dying? So commonly that's where this happens. This can happen obviously in a specialist physician's office as well. We commonly see that happening in an oncology clinic, or at a time in care when an oncologist may be saying to a patient that there's no more active treatment available for them. Patient might then bring up the issue of assisted dying. This can happen in a hospital setting when a patient's in the hospital for a complication of their illness, for example. They might bring it up to a hospitalist or a different specialist. This can be brought up by family members, by friends, but it has to be the patient that makes the request. My point really is that information about this care is ideally available to patients from a variety of sources, from a variety of healthcare practitioners who all need to be able to at least respond to the initial inquiry. Of course, our law makes it very clear, and we must support and absolutely respect any practitioner who wishes to refrain from being involved in this care, and our law explicitly protects their right to do so, to decline to be involved. So in such a situation, we would only expect a professional response, which would be what we call an effective transfer of care, or an effective timely referral to some source of adequate information, so that the practitioner doesn't need to be involved. Can a clinician ever bring up this topic? It's a question I get asked a lot. The quick answer is, in Canada, yes. It is sometimes appropriate to do so. There are other jurisdictions that explicitly do not allow clinicians to bring up the topic. Famously in Australia, it's written into the law that clinicians cannot bring this up. It must come from the patient. But I would argue that anytime a physician is laying out options for a patient to consider, they must lay out all the options. Otherwise, the patient is essentially being coerced otherwise. This is true of medical treatment, of surgical options, of chemotherapy options. If I have a patient who has appendicitis, I need to tell them about the pros and cons of having a surgical intervention, the pros and cons of doing nothing, the pros and cons of being on antibiotics and trying to avoid surgery. They need to have all of the options. If I only give them one option, I think that's essentially not just unprofessional, but probably malpractice. And in Canada, we feel that if it is the right time and place to be talking about end-of-life options, the issue of assisted dying can and probably should be brought up by clinicians in an appropriate way. Now, of course, it must require certain skill. You don't just blurt out, hey, did you want to hear about assisted dying? Essentially, what I always do is ask for permission. Mr. Smith, we've been talking about the difficult situation you're in. I'm so sorry it's come to this. I'll be here for you no matter what you want. We've discussed some options for you to go home and consider, to discuss with your wife. I know this is tough. I'm wondering if you'd like to hear more about the option of assisted dying, or is that something you'd rather not discuss? I mean, you can always ask a patient for permission before you bring a topic up, but it is important in Canada to have that option available. Next slide, please. There are, of course, some official procedural safeguards in place. So just to mention, in Canada, you do need to make a written request. That request needs to be witnessed by 2 independent witnesses. There have to then be 2 clinical assessments to make sure the patient meets the eligibility criteria for assisted dying. So they have to be separate clinical assessments. There is then a mandatory 10-day waiting period, what we call a reflection period, for the patient to consider their decision, to further discuss it with loved ones if they wish, give them extra time to consider changing their mind. Consent is required in Canada, both at the time of the written request and at the time immediately before the provision of the care. So capacity and consent need to be present when a patient requests this care, and also on the day of the provision as well. And our law, of course, mandates a certain national monitoring and reporting of activity of what's happening. Next slide, please. In terms of the process after the written request is made and the procedural safeguards are happening, what happens next? The assessment, of course, can happen in a home, in a hospital, in my office, in a variety of settings. Next slide, please. So what are the eligibility criteria? Again, very briefly, I'm just going to go through this so you have a sense of this before we go on to some examples. In Canada, there are 5 things that need to be true to have an assisted death. A patient does need to be an adult. They need to be over 18 years of age. They need to be eligible for Canadian healthcare. So we're not interested in people coming from other jurisdictions, even if they're paying privately. They cannot access assisted dying in Canada unless they're already eligible for Canadian healthcare, essentially people who have status here, citizens, permanent residents. The third requirement is that the patient makes what we call a voluntary request, that there's no sense of coercion, either explicitly or even subtly, that the patient is acting of their own accord, and it's my job to make sure that's true. The fourth issue is that the patient has capacity to make this decision, meaning that they understand what they're requesting. And again, that capacity needs to be present when they make their request and again on the day of the death. And the fifth criteria is the most complicated. It says the patient needs to have that term again, that grievous and irremediable condition. Our law actually currently breaks down the definition of a grievous and irremediable condition. So in our federal law, it says in order to have a grievous and irremediable condition, you must meet 5 other conditions. This is a robust and rigorous system. It says you need to have a serious illness. That illness needs to put you in what's called an advanced state of decline and capability. So it's not that the disease is advanced, but it's that you are no longer functioning in a way that you used to before this disease, and in an advanced way, not a small decline, but an advanced decline of function, essentially. That advanced decline and your illness are irreversible, by any means acceptable to you. So you're never forced to undergo therapy, but if there's nothing available that's acceptable to you and you cannot reverse your decline, that's an essential component. That you are deemed to be suffering intolerably. So obviously a very personal criteria. It's not for me to say what causes somebody else's suffering, nor is it for me to say how much of that suffering they can endure before it becomes intolerable, right? I can have 2 women with the exact same diagnosis at the exact same stage of illness, both of them telling me they're suffering. One of them might ask for my help 10 days later. The other one might want to wait 3 weeks because they're expecting a great-grandchild. I mean, that's a very personal decision, and I respect the patient's input on that criteria. And of course, the last criteria is that a patient's natural death is reasonably foreseeable. And I could spend an entire week trying to talk about each and any one of these. I would just highlight that this obviously is an attempt to put a temporal window around who is eligible for assisted dying in Canada. And the meaning of that phrase has been much debated. And I have it highlighted because we're in the middle of a process right now that will be removing that criteria from our law. So I'm going to just leave that where it is right now. Next slide, please. That was a lot, I know. So in doing an eligibility assessment, when I go and sit and meet with the patient, what kinds of questions am I asking? What am I looking to find out? Well, essentially, the conversation that I have with someone is meant to help me elicit whether these criteria are true or not. So I might ask someone, one of the first important questions I ask someone is, why now? Why are we talking about this now? We didn't talk about this 3 months ago. You didn't ask to wait to see me for 3 more months. What made you decide to ask your doctor for help now? What's changed? What's your understanding of your illness? What's wrong? Is there anything you could do a year ago that you can't do now? Why can't you do that? You know, what is it that still brings you joy in life? What causes your suffering? Are you suffering? So essentially my conversation is around these eligibility criteria, but I always make sure, this is like my little clinical secret, I always make sure to ask people about their life. I actually spend a fair bit of time speaking about their life story because I find I want to hear about where they grew up and where they went to school and what they chose to study, who they fell in love with, and tell me about the dynamics of their family. I find when they tell me these stories, I get a sense of what's important to people, where they've focused their life, what's what interests them, and it helps me determine their eligibility for this very important decision. So I think that's really the essence of what I do. I would just maybe add that I often get asked about coercion and questions about how I make that assessment. We can talk a little bit more about that later. I would just reinforce that clinicians make assessments about capacity and coercion every single day in their office. Every time we offer a medication to a patient, we need to be sure that they understand what we're talking about, what we're offering, how it works, what the pros and cons are, that I'm not coercing them into it, but that they have a full understanding of why I'm guiding them to accept this care. So we do assessments of coercion and capacity routinely, dozens of times a week. I don't think it's really so different in the situation of assisted dying. It just seems that the outcome and the stakes seem higher. But I always let people know that it is a skill that clinicians already have. It's not a new skill. And one thing that I do when I'm meeting with patients is I always make sure to meet with them privately so that I can be sure that there's no sense of coercion from anyone else. Next slide, please. What I want to do really is talk to you about some examples. Next slide, please. Great. So I'm going to give you an example. This is Mrs. XX. This is a woman I met. This is based on a woman I met in the first couple of months of assisted dying. I met her, she was 66 years of age, but when she was 61, she had a diagnosis of an oral cancer in the back of her throat. It was devastating for her. She had quite radical surgery to remove it. She went through several rounds of chemotherapy over the years. She had several rounds of radiation. She really went through the whole gamut of what could be done to fight this disease. And she did quite well for several years. But by the time I met her, of course, she was in significant decline and there were no more active treatment options available to her. I should mention that she had outstanding palliative care services available to her. I'm very lucky where I live. We have excellent palliative care services. They were supporting her in her home. She felt very strongly she wanted to remain independent. She's a very independent woman. She had family and friends all supporting her. But she really felt that she wanted to control the terms of the end of her life, which she saw coming in short months. So she went to her family doctor who'd been supporting her through these years, and she said she was interested in the topic. Her family physician did not know anything about the issue, but she was aware that I was in town and did this work, so she referred her to me. I got the referral, and I actually went to this woman's home. This is how this works. I go to her home, and I spent about probably an hour and a half, 2 hours with her the very first time I met her. The first time I met her, the second time I went, I met her ex-husband, her partner, the 2 children, so lots of people. And we reviewed what was important to her and why she was having this conversation. And it was quite clear in her case, medically speaking, she met all the eligibility criteria for an assisted death. I spoke with her oncologist. He very much wanted to be the second assessor on this case. He brought her into the office. She was able to go there, and he filled out his set of paperwork, and I filled out my set of paperwork. And ultimately, I was able to tell her that she was eligible for this care if that's what she wanted, and she was quite relieved to hear that. This woman did something quite unique. She wanted to very much not just be in control of the term, she wanted to actually set the activity in motion. She did not want to die at home. She did not want to die in a hospital. She wanted to be very much in a beautiful setting that she could choose. And so she called a particular hotel in our city that had a beautiful waterfront view. And very transparently, she told them that she wanted to have an assisted death in their facility. And much to my surprise, they agreed. So she checked in 3 days before her assisted death was due. She literally held court on a king-size bed in her hotel room. And for several hours at different times on different days, people of her life that she worked with, that she played cards with, people of her life would come in and visit her and say their goodbyes. And on the day of her assisted death, I showed up with my nurse and my medication. There were about a dozen people in the room that she had chosen to be with her. They encircled the bed that she was laying in. Her children were on the bed, grown children were on the bed holding her. She had made a playlist of music she wanted specifically to be happening. There was family photos on a big screen TV scrolling in front of her. And at a certain point in the playlist, she asked me to go ahead and give her medication. And I did so. And she had a very peaceful falling asleep and then into a deeper comatose state and fell into death in the exact time and place that she wished, with the exact people that she wished, in the exact setting that she wished. And I found it a very, very moving, a very emotional, and very beautiful event, to be honest. Next slide, please. That's not how all of these look, of course. I'm just looking at the time. I do want to tell you about two other situations. For example, Mr. XY, a 74-year-old gentleman who I met who had late onset progressive ALS over the course of several years. He'd been a very, very active man before this, cyclist. But now, of course, he was confined to a wheelchair, and he found the request form not through a physician, but online. He searched this out himself. He filled in his request form appropriately. He spoke to his own specialists about it, telling them what he was planning to do, and he convinced his respirologist to be one of the assessors. He happened to be in hospital having a feeding tube surgically implanted into his stomach, which is very common for people with this illness to have placed, because they will eventually come to a place where their swallow is very, very difficult to swallow. So they have the option of this feeding tube to maintain their nutrition. He was having that done, and he asked me to come see him in hospital, where I saw him and assessed him. And it was clear for both of us that his prognosis could be many months, if not even a short year, before he was expected to die. He told me very clearly he wanted to have an assisted death before he got to the point of needing mechanical ventilation to keep him alive. He was not interested in that. So we were able to talk about what his wishes were, and I was able to follow him along over a course of time. What we call this is, we call this made in the back pocket. I often see people coming to me at this early stage wanting to be assured that I'll be there for them when the time comes. And so technically I can't check off that he's eligible on the day that I meet him. He's not. But I tell them that I'm doing a rolling assessment, and over time we stay in touch with each other. And if that decline happens and he maintains capacity and every other criteria, then of course I can step in. And this gives patients a large sense of reassurance that this is possible. Next slide, please. So I would just emphasize here that telling someone that they're eligible for an assisted death, just telling them that that's true, is probably the most therapeutic intervention that I do, more so than any action or activity. I see this over and over again with people. I see the relief on their face. I hear the gratitude from them, even if they never proceed, no matter how they die. I've already done something that I believe is incredibly important for this patient by telling them that this is available to them. And that's one thing I want. It's a take-home message I'd like to give today. Next slide, please. I would just very quickly tell you about someone who's not eligible. People ask me about this all the time. Mr. ZZ is 83 years old. He's a widower. He's got a little bit of this, a little bit of that, a touch of CHF, a little bit of hypertension, but he's quite active. He can still drive. He can still get down to the local pub, but he is tired. He's tired of the way that he's living. He's unhappy since his wife died. He lost his family doctor. He's got a new young person he doesn't like. He doesn't think this person understands him. He's a bit grumpy, to be honest. And he is self-referred. He's called my office and called me up and said, look, I'm done. My best years are behind me. I would like to end it. Thank you very much. I think my life is complete. I'm no longer contributing to society. Please help me to exit. And I would just make clear that our law does not allow for that. That is not someone who can meet the criteria of pretty much any jurisdiction in the world. It's not death on demand. That is not a term that we use. This patient, his death is not reasonably foreseeable. He's not yet in an advanced state. He is suffering, but it would be arguably not intolerably at this point. So just to clarify that. Next slide, please. Where might we be going? Next slide, please. As I mentioned, we will be removing this particular eligibility criteria. I'm not going to dive into that. Next slide, please. I think I would just end here because of the time, just to say that assisted dying in Canada is available, it is legal, it is functioning. We have a rigorous process with multiple safeguards in place. We've had 2% of all deaths in Canada are now attributed to assisted dying as of 2019. I do see a tremendous amount of relief and gratitude when I do this work. And I would just add that I would reinforce that I do find this work very rewarding. I find it very privileged work, and I'm happy to answer any questions you have. Next slide, please, about any aspect of this care. So I thank you for your attention.
Thank you, Dr. Green. Very interesting. In the UK, doctors have a duty of care to their patients. Should not this include a duty to provide a dignified and peaceful death?
So I guess as a physician, I feel clinicians have many duties, as a matter of fact. We have the duty to maintain confidentiality with our patients. We have We have legal duties, we have moral duties, as you mentioned. We have a duty to provide a certain standard of care and to use a certain skill set when we do it. I think that upmost in our minds, we have a duty to preserve and protect life, but also a duty to reduce suffering. And maybe I'm ducking your question. I think that caring for patients as they die is certainly part of what physicians do and our duty. So you're asking, do we have a duty to provide a dignified and peaceful death? Certainly, we would all hope to do that. I think fundamentally what physicians do is help people, no matter what we say and how we say it. That's ultimately what we do, is we help people. And death is, of course, on the continuum of life. And so it is my opinion that it is our professional responsibility to help people at every stage of their life, which includes their death. So I don't think this falls outside of that. I think an assisted death in particular is a very specific type of care that I think physicians are quite honored to be called to assist with. And whether our society believes that we have a duty to provide that, I think it falls within the mandate of clinicians to do so. I happen to agree with you, yes.
Clearly, people's life experiences will help them consider this very delicate situation in different ways. When I was fit and healthy, I found the idea abhorrent. However, I'm getting old with a spinal cord injury sustained in 2005, which left me an incomplete tetraplegic. Now I can look upon the situation with different eyes. Is it right to ask someone to accept the responsibility for giving you the means to die, for it will live with them forever?
Thank you. Thank you for sharing your story. I think you're asking me about whether it's fair to ask someone like myself to administer this because it's going to live with me forever. Did I understand that correctly? I think that's the question. So I appreciate the question and the concern. So as I've mentioned, I feel that it is an incredible privilege to be invited into such an intimate time with a patient. I've felt that through my maternity career, and I feel this just as strongly in assisted dying. I think I would just emphasize that, of course, no clinician is ever forced to do this work. So nobody need to take on that responsibility if they're unsettled with it in any way. Our legislation explicitly outlines that. And everybody and my group, everybody in Canada really supports and respects the decision of clinicians to conscientiously decline to be involved. I would also say that those of us who've chosen to be involved, there's nothing compelling us at any time in any particular situation to continue. So if I come across a patient that for some reason the situation feels uncomfortable for me, even if I believe that they meet the law and all the eligibility criteria, there's nothing forcing me to continue. I'm human too. So if I come across a situation that triggers something personal for me, I might have a family member with a certain situation and I feel uncomfortable helping someone, I can simply refer this to a colleague. There's nothing that compels me to do this work. So while I appreciate your concern, I think those of us who do this work walk in with open eyes and with open hearts to do this work because we think it's important and we feel that we're capable of doing it. So I do think it's fair to ask, and anybody who's not interested does not need to. People talk about conscientious objection. I like to talk about conscientious participation. I think both are equally important.
If assisted dying were to become lawful in this country, people would need to feel confident in the safeguards against inappropriate use. What are the most important safeguards in your view, and how do we make sure they're effective?
Well, that's $1 million question. Thank you. That's an important one. There's certainly been much debate in Canada and all other jurisdictions where this exists about safeguards and what's appropriate and what's not. And it is really essentially what differentiates different jurisdictions. People joke in Australia, which is relatively new, they've been having assisted dying since 2019. They have over 60 safeguards in their law, and they joke about it being the most conservative law on the planet. I think that there's a balance to be had there because it also creates a certain amount of obstruction, right? I mean, legislation and government, society, we need to find the balance between safeguards for the most vulnerable in society, which is essential, and the respect of and the right of an individual to make autonomous decisions for themselves. And sometimes there's conflict between those, and we need to find that balance. That balancing act is admittedly difficult. And I think the ultimate safeguards that are chosen in different jurisdictions really reflect how the law and why the law changed in this jurisdiction. So I'm skirting your question for just a moment. In the Netherlands, this was essentially of a recognition between conflicting duties of a clinician to, you know, to safeguard life and to reduce suffering, that they were conflicting. And so their law talks about a due care criteria that reflects what the physician's responsibilities are. In Canada, this comes out of a charter challenge. So it's a human rights-based issue. So our system is patient-centered and builds out infrastructure based on the patient's need and based on the patient's suffering. So how we come at safeguards is different as well. I feel like I'm ducking your question. Let me get more to it. For example, there's often, what we're finding is, for example, right now we have a 10-day reflection period mandated in our law, and many jurisdictions have mandated reflection periods. What we found in the last 4.5 years in Canada is that there's absolutely no evidence that this has safeguarded anyone from anything. In fact, what we've got more data and good evidence for is that 10-day waiting period has created more anxiety and more problems in patients, because the number one concern of my patients once they're deemed eligible is that they're worried they're going to lose their ability to make this decision, or something unexpected might happen in their illness that they won't be able to have this choice. And in fact, they restrict themselves from taking medication or receiving certain care for fear that it will cloud their judgment and be able to go ahead. So actually we find it causes more suffering. And that's one of the reasons we're planning to remove that criteria any moment now. So I think safeguards are important. We need to find the right balance, but we need to evaluate them. I still am ducking your question. For me, the most important safeguards are literally that society has adequate resources in the community. So community supports, senior supports, disability supports, mental health supports. There needs to be a reasonable effort to have adequate resources available to all in the community. And on the flip side, we need good clinicians that know what they're doing, that have standards of care, that have training to do this work, that have networks of professional support. So if we have both of those things, that's the most important thing, because then patients can be left to make the most important decision for themselves based on their own autonomous compasses. And that's my way of ducking, but I think that's the best answer I can give you.
What kind of support is given to the relatives and friends of the person who's decided to end their life in this way? It may be difficult for them to come to terms with the decision, and their grieving will have already begun.
Yeah, that's a great question. Thank you. And in fact, I think we came to it quite late in our jurisdiction. I mean, it quickly became clear to me on the day of someone's death that, I have this private conversation with patients right before we start, and inevitably, 99.9% of the time, people tell me they're quite settled, they're quite ready, they're eager to proceed, they've very much accepted their choice. They've been thinking about it for months, if not years. But the patient's family, of course, is deep in grief. That day and the days after and the weeks after, of course, are much harder for the family than for the patient. So that's very, very clear in my work. I think in the beginning, we were very eager to make sure we did this work carefully, rigorously, and with a structure in place. So all focus was on infrastructure and patient needs and patient access. And we slowly, within 6 to 12 months, came to the realization that we needed better supports for families. And now we see that happen. So we have enough experience now that we know how important that is. So the answer to your question is we have general bereavement programs through most hospice and palliative care facilities in our city that are open and free for patients' families to access immediately or even in advance of the assisted death. We have specific support groups meant for those who've lived through an assisted death with a loved one. And we have also online resources in case people are shy to reach out and don't want to go to ask anyone. They can, in the comfort of their home, access supports for those who've lived through an assisted death with a family member. And there's community forums and all kinds of supports online. So I just need to make that go. So yes, so I think we're developing them more and more.
How can one ever be sure that the person is emotionally sound when making a life-changing decision about assisted dying?
Yeah, so I alluded to that a little bit earlier. It's a super important question about capacity and mental stability. So I would reiterate, physicians, clinicians, nurse practitioners, we do this all the time with every patient in every interaction. Now, obviously, the stakes seem quite a bit higher here. So I would just break down for you, when I talk about someone having the capacity to make this decision, specifically what I mean is I need the patient to be able to demonstrate and communicate to me that they understand what their illness is, what's wrong, that they understand what their treatment options are, pros and cons of them, including palliative care as a treatment option, that they understand what an assisted death is, that they understand if they have an assisted death that they will die, and that's irreversible. They can't be confused about that in my mind. They also need to understand and appreciate what their life will look like if they don't access an assisted death, that there will be a further decline in a different way. And if they have all of those things, if that understanding is clear of all of those things, and they appreciate their situation and articulate a request to die knowing all of that, I consider that an informed decision. They prove to me they have capacity. When we were talking about mental health and emotional stability, I'm not sure if that's what you're getting at, that's part of that assessment. If someone has an acute psychosis, those first things will not be possible, and they will not be eligible for care. If someone has an acute depression happening, that will cloud their insight and their capacity to make this decision. But just because someone has a history of depression, or they have a well-controlled depression, but they also have pancreatic cancer, certainly people can still have capacity to make their own healthcare decisions despite mental health. So that's what we do. We assess capacity in mental health all the time in every patient, but especially carefully in these patients. That's what I do. What you're asking me is, do I know how to do my job? I don't mean to be cheeky, but that's really what you're asking me. And I tell you, yes, I know how to do my job.
The next question is, why did Canada not choose to limit assisted death to those with 6 or fewer months left to live? And what do you think the effect would have been if Canada had?
So I think I touched on it lightly. The way our law changed in Canada is different, quite unique compared to other jurisdictions. So in the United States, it tends to be voter ballot initiatives where the people rise up and say, we want to talk about this, we want this change in Oregon or Washington State, and they make a change. In the Netherlands, as I explained, it was about physicians having conflicting duties, and the government recognized that and found a way for physicians to not be criminally liable if they act a certain way. But technically, it's still illegal to have an assisted death in the Netherlands. In Canada, it came out of a charter challenge, and I keep going back to that. I keep going back to the fact that it's a human right, because in Canada, the recognition is about the patient's suffering and a certain situation in which they're suffering, which needs to have the ability to be helped and assisted by a physician. That has nothing to do with an end-of-life regime. So most other jurisdictions have what we call an end-of-life regime. It's connected to them dying. And so they have put on terminal illness, 6-month prognosis, anything to try to contain the eligibility to someone near end of life, all of which is, of course, very fuzzy and difficult to do. In Canada, the original decision had none of that. It is not about a dying person. It is about a suffering person. Now, our government created a law that tried to box that into a semi-end-of-life situation by requiring that the patient's death be reasonably foreseeable, whatever that meant. But we knew on the day that they made that law that that was going to be unconstitutional and not in line with our high court decision. And in fact, 4.5 years later, we recognized that, and our law is about to change. So we are not an end-of-life regime. We're never meant to be an end-of-life regime. And so that's why it didn't happen. The effect, of course, is that it is obvious, is that it reduces the amount of people who are eligible for this care. And I can, of course, list to you the number of people that suffer whose life is not 6 months away. And so we've allowed people with chronic neurodegenerative illnesses, for example, to still be eligible for this care if they feel it's important for them.
Has the introduction of your law made any difference to palliative care in Canada, for better, for worse?
Yeah, this is always a fear that this will reduce the need for or funding for palliative care. So as in every other jurisdiction where this is true, in fact, the opposite is true. Palliative care has been funded more in Belgium and in Canada and since the addition of assisted dying. I think what's ironically happened, the topic of assisted dying is very headline grabbing. It creates and generates a lot of discussion amongst people in a variety of settings. And in truth, what's happened is it has brought the issue of death to the public's mind in a very obvious way. We are talking in Canada more about dying and what's important when we die and how we die. And that conversation has expanded exponentially since assisted dying has been legalized. And by virtue of that, we are talking much more about the importance of palliative care, the need for quality of palliative care, the need to fund palliative care. They've received more funding. And my palliative care colleagues sheepishly admit that it took the addition of assisted dying in Canada to get them on the dashboard. Not the way they wanted it to happen, perhaps, but in truth, it spotlighted palliative care and our need for it.
The next question is, have you ever supported anyone whom you thought had in any way been pressurized, and how did you deal with that?
Yeah, so we're going to play on words. I certainly support all my patients no matter what, but I certainly didn't let anybody advance to an assisted death if I thought there was a sense of coercion or there was something wrong. So I've had very, very few patients who I've felt have been coerced. The one standout example I think of is a gentleman whose sister seemed to be really driving, and I thought she was just trying to access care for him. He was intellectually challenged, but it was so obvious to me that she had filled out his request form in her writing and had signed it for him and had gotten 2 witnesses. It's a great example of how some of the safeguards we put in place, they're not as important as a conversation with the patient, because he had a form that was filled out. He had 2 witnesses who said that he had signed it, but it was clear as bell to me that he had not written it. He cannot write in a steady hand, and there's this beautiful loping signature. It was clearly not his. So I supported that man by finding him other resources and explaining to him why assisted dying might not be an option for him. And I helped him to find those resources. So I'd like to think I supported him, but I certainly did not allow him to proceed to an assisted death.
Here in the UK, many people have an advanced decision statement which details their considered choices in case they should become seriously ill or incapacitated. Does Canada have the equivalent form of this, and has it proved to be useful for doctors as well as patients?
So yes and no. So we definitely have advanced directives. We call them advanced directives, as I think you probably do, or advanced decision statements. We have them in, I think, every jurisdiction in this country. They're encouraged. They're certainly, we encourage patients to fill them out. They are generally respected when physicians know about them, which is not always the case, but it is very, very clear, just to be 100% clear, there is no way an advanced directive or an advanced decision-making or any healthcare representative can make a decision about assisted dying. It's the one thing that's not included. So you can make decisions in your advanced directive or advanced decision statement about what you might like, or when you might like life-sustaining treatment to be withdrawn, or all kinds of decisions, but you cannot in that statement in Canada talk about accessing an assisted death. It can never trigger an assisted death for you. You can never in advance say, if A, B, and C are true, I would like you to go ahead with an assisted death. That is not legal in our country at this time. Obviously, many people would like it to be that way. There's much debate about that. That's a very difficult conversation that we are about to enter in Canada about advanced requests for assisted dying, but advanced health statements are legal, they're considered, they are utilized, they are respected, but not in respect to assisted dying.
With that last question, we come to the end of our webinar. I would like especially to thank Dr. Stefanie Green for the direct and clear insight she has given us on this issue. We wish you well for the future.